Alright class, so we were talking about the foot and toe evaluation. We did talk about some of the good additional questions that you can possibly ask during a history taking something about shoes or training surface, weight, pain, stuff like that. And we were talking about observational findings, some of the things that you might want to look for. One of the things was arch, and the medial longitudinal arch to be very specific, and also the toe lengths. Okay, it's not that say this one square foot is worse or better than the other toe length shape. It's just that if you happen to have specific say toe lengths like Morton's foot, then you might be more than likely to experience a very specific type of foot injury compared to others. Next observational things that you might also want to look for is the foot and calcaneal alignment. I will give you two examples in this slide. The good one is a forefoot varus and forefoot valgus. We did talk about different lesions in the foot. We talked about the rear foot and midfoot and the forefoot. Sometimes you can have alignment issue happening right at the forefoot, which is the very front part of the foot. So looking at this one, the forefoot varus on this side, what you can see is the tibia and fibula lined up perfectly straight, and your talus right there is also doing okay, nice and straight. Your calcaneus is nice and vertical as well. What you have here though is your toes are a little bit rotated. Your pinky toe is down here lower compared to the big toe, which is a little bit higher. So what you're experiencing in the forefoot is an inversion of the forefoot. It's turned in. Okay, this is what you're going to see in a non-weight bearing position, meaning that your patient's leg is up in the air, maybe they're sitting on a table or something. But as soon as they put the weight on a foot though, everything is going to change. Okay, because your toes are going to want to turn so you can grab the ground nice and good. Okay, so you have a nice full contact. So it looks like your toes are now completely straight and flat. Okay, the problem is though, because it was rotated to begin with, it's going to take your calcaneus with it now. Okay, so calcaneus, which you didn't have any problem here, now it's turned out. It's now everted. It turned towards the pinky toe. Okay, so it turned outside. We call that as calcaneal eversion. Also, look what's happening here at the subtalar joint. When I say subtalar joint, that's a joint that you can find right there between the talus and the calcaneus. Subtalar means below the talus. So look at this joint right here. I see a nice wide opening over the inside, okay, of the subtalar joint. So now we actually call that motion as a pronation of the subtalar joint, or pronation of the foot. It's dropped. The medial arch that you had over the medial side, the big toe side, has completely dropped because of the significant pronation that you would experience at the subtalar joint in a weight-bearing position. Forefoot valgus is the opposite of that. So you again, tibia, fibula doing just fine, your talus is fine, your calcaneus is fine, but look at your toes. Your pinky toes is now lifted higher compared to the big toe. So now you can say this forefoot is already in the valgus position. It's turned out. Okay, it's kind of facing towards the pinky toe a little bit more now. If you have to put weight on it, okay, your toe is gonna rotate back. So your pinky toe is now down on the ground, which is good, but again, it's going to take your calcaneus with it. Your calcaneus is now facing inward, as you can see in this picture, inward. Okay, and at the subtalar joint, you're going to see a nice opening over the lateral side of the joint, so we call that a subtalar joint supination. The picture on the top is showing the forefoot varus, because the calcaneus is now turned out. This picture in the bottom, look, it's showing the forefoot valgus, how it's going to adapt when you put the weight on it. You can also experience some alignment issue at the real foot. You can experience the real foot varus and valgus, but the real foot valgus is not as common. So we just gonna mention the real foot varus in this slide. So this is a real foot issue happening at the real foot, which is the calcaneus and talus. So looking at the tibia and fibula, doing okay, your talus is doing okay, but your calcaneus is already inverted. Okay, and your toes are not rotated compared to the plane of the calcaneus. They just kind of moving with the calcaneus. So forefoot is not doing anything special. It's just that the real foot is already turned, like you can see in this picture. So if the patient is say sitting on a table and then having the leg relaxed, what you might see with the patient with the rear foot varus is the calcaneus is already turned, okay, and it's going to take the forefoot with it. So forefoot is not doing anything wrong. It's just that the calcaneus is already twisted, so it's going to move with it. If you have to put weight on it, on this foot, your calcaneus is going to now rotate back, so your toes and then the calcaneus can grab the floor. So the calcaneus is looking now vertical. It's nice and straight. It looks like you don't have any problem. But what you might see here is a nice subtalar pronation to kind of make up for it. You start to see some compensation in the joint that's right above. Some other things you can see, you can look at the people's toes and how they were doing there. Sometimes you see specific deformity. The picture on the top is showing the hammer toe. Okay, so what you see here is the MTP joint getting hyperextended in a position of extension beyond the limit. Here the PIP joint is stuck in a flexed position, but the DIP again on the very tip is now hyperextended. So you see the pattern of hyperextension, flexion, and hyperextension. Okay, we call that as hammer toe. This condition is often associated with the contracture of the extensor. So the extensor is tight and then pulling that finger. Okay, and also maybe the contraction of the flexor that's pulling the toe close. Claw toe is looking a little bit different compared to the hammer toe. I want you to pay attention. You see the hyperextension at the MTP, which is the same, and then also the PIP flexion, which also is the same. The only difference is the DIP, the very tip. This one is extended, and this one is flexed. So with the claw toe, you see hyperextension, flexion, and flexion. That's the difference between the claw and hammer toe. So here's a quick question. Which one is this? How would you classify this one? Again, what was the key point? You look at the DIP, right? DIP right over here. Then what is it doing here? Is it extended or is it flexed? I would call that as hyperextension. It's more in the position of extension. So this is a picture of the hammer toe because of the DIP being hyperextended. And you would often see with a patient like this kind of a toe deformity, you often see the callus formation here on top of the PIP because the PIP is flexed within the shoes, and then maybe you start to experience some friction up against the shoes. So gradually maybe they start to form some callus over there. Some other things to look for: halcus valgus, which is a valgus deformity happening at the halcus, which is a big toe. So here, this is a picture of the very, very slight halcus valgus. Okay, look at the first MTP joint here. Looks like the first metatarsal is going out, and it tried to make up for it by bringing the proximal phalanx in. This is a very slight one though. It's not as bad as this one. You're gonna see a nice sharp angle here, going out significantly and then coming in. Okay, this is a pretty bad picture. You see the nice sharp angle. Often you will even start to experience some subluxation of this particular joint because this bone is supposed to connect to right over here. Some other things to look for: I would definitely look for some exostosis, which is a fancy term for the bone spur. Maybe they have that at the calcaneus, maybe the tarsal has, but I'm going to look for that. Also, some people might be experiencing the ingrown toenail, which might need some intervention, maybe something like this. And then also syringeal hematoma, which is a blood collection underneath the toenail, which is typically very painful. Other things, maybe callus formation, blister, or some other any skin conditions. Maybe they have some kind of infection going on in the toe. It's not very uncommon, so look for those things. Here are actually two interesting pictures of the patient that I happened to come across in the past. I actually did get this permission of this patient to take these pictures, but this is a very, very interesting set of the foot, I would say, set of the feet. What I see in this individual, and this individual happened to be very, very tall, by the way, very tall. What I see here is a very high arch, a lot of callus formation here in the bottom of the big toe. So I can only imagine how this patient is, say, walking or running around. I'm pretty sure they're putting a lot of weight over here, the ball of the metatarsal heads, as well as the calcaneus, and then maybe almost no contact right over here. And look at the big toe. He's got the nice long big toe. And you're gonna see a little bit of a deformity here. Okay, he's almost got the permanent flexion of the toes here at the IP joint. You can also see that as the and the PRP joints over here too. What happened in him, if I can share a little bit of his story, was he was getting really tall when he was a child, and his parents are almost started to feel a little scared that he might get too tall. So what his parents ended up doing was they intentionally bought him a pair of shoes that were very too small for him. They were thinking and hoping that it's maybe going to stop him growing, even taller than that. Which unfortunately didn't happen, so he kept growing, so he got taller and taller, and unfortunately what he ended up having was a lot of foot and toe deformity from wearing a very small pair of the shoes. So he was having a lot of foot pain, as well as the shin pain coming in. We needed to do a lot of foot intervention, custom orthotic intervention for this one. Moving on to palpation, I think we mentioned a little earlier, but when we start to do palpation, we have to always start with the bony palpation. Make sure that this patient is not having any significant bone tenderness. If you say press on one spot, for example, maybe the base of the fifth metatarsal or something, and they have significant point tenderness, you may not even have to move on and do more of a test. Maybe that's enough for you to say, okay, I suspect a very good fracture there, so I'm going to stop because I don't want to move that ankle any more than that, and we need to maybe make our immediate referral. Okay, that's the purpose of why we are typically going to start with the bony palpation. So I mentioned all these bones today. Okay, so make sure you can palpate all the phalanges, metatarsal, MTs for metatarsal, and DIP, PIP, and MTP joints. Specifically, the styloid process of the base of the fifth is a very important spot for you to palpate because it's a common fractured site. Sesamoids, cuneiform, and all the tarsal bones. Ligaments. Make sure you know how to palpate these ligaments, as well as maybe the arch. You can even check for the mobility of those arches, as well as checking the pulse. Sinus tarsi is maybe the only spot that we haven't really talked about yet. Sinus tarsi is a spot that you can find if you have to look at this picture, and you can see the lateral malleolus, which is the distal part of the fibula. This little indentation that you see right in front of the lateral malleolus, that is your sinus tarsi. And if you're to palpate, it feels like indentation. It's kind of an empty spot. Okay, this is a nice spot for you to know, because if you're to palpate somebody's sinus tarsi, which is over here, you can also easily find the ATF ligament, which is the anterior talofibular ligament, most commonly a sprained ligament in the ankle. We're going to talk a little bit more about this ankle once we get to the ankle and lower leg chapter, but it's a very, very important ligament for you to be able to identify. Okay. Also, if you have to get an X-ray of the sinus tarsi, see, this is the empty spot. Because it's so empty, it's a perfect spot for the swelling to sit. Okay, when you experience an injury like an ankle sprain, or maybe the foot distal lower leg fracture, something like that, the swelling might start to come down with the gravity, and it's going to be a perfect spot again for the swelling to sit. So with a significant foot or ankle lower leg injury, you would often see the swelling right on that spot. I'm going to stop right over here before we start section 2 of the presentation.